please. We're good. Okay.
We're not quite at 1:30, are we? Is it half?
It is, it's 1:30.
Right, good morning members, officers, and a warm welcome to our guests. Thank you for coming. We are live streamed now, just so that everybody's aware. Have I your permission to sign the minutes from the last meeting? Are they all present and correct? Thank you. Can we have apologies for absence, please?
Yeah, apologies for absence from Councillor Anderson for medical reasons, with Councillor Taylor substituting, and apologies from Councillor Martin, with Councillor Paju-Haran substituting for other reasons.
Okay, thank you very much. Well, welcome to the temporary members on this committee. Declarations of interest, please, from members and officers. Disclosable pecuniary interests, anybody? And private interests. Councillor McGrath.
Chair, my daughter's trying to be a nurse, she said.
Yeah, and I have an interest too because my daughter works at Queen's Medical. Anybody else? No. Right, so you will see on your agenda that we have the work programme next, because we were going to, our officer here suggested that we changed it around. Clearly it's not convenient, so we're going to revert back to as it always was. So we'll put the work programme to the end. Sorry, Councillor Welsh, did I miss you out?
No, you didn't. I don't know whether I should be or not saying this, but I'm on a waiting list for treatment at NUH. And I didn't know whether I needed to declare that as an interest, since we're talking about NUH at some point.
I personally wouldn't have thought so, but...
Okay.
So... Noel says not, so...
Yeah, sorry, I would advise that that's not necessary.
Right, before I introduce our guest today, I would just like to say a thank you to my Vice Chairman, Councillor Bethan Eddy, who over the last couple of months has looked at the quality accounts and made comments, and it included EMAS, NUH and the NHS Foundation Trust. No, that was, yes, that's right. And Councillor Welsh, thank you, you looked at the Sherwood Forest Hospital Foundation and did a report for us on that. Thank you very much. I know they're quite a lot of work, and I do thank you both for doing that work. Right, so let's move on. We have our guests, and I'm going to let you introduce yourselves and tell us exactly your position at the hospital.
Thank you very much. Thank you very much. Should I stand to do the presentation?
No, you just introduce yourself and then you can start your presentation.
Okay, thank you.
And no, you don't have to stand.
Okay, thank you. So I'm Amanda Sullivan, and I'm the Chief Executive of the Integrated Care Board. Thank you.
Good morning, everyone. I'm Prema Nurgday. I'm Head of Insights and Engagement for the Integrated Care Board.
Thank you. So now it's over to you, two ladies, to take us forward on your briefing.
Thank you very much. It's really actually a privilege to be here, and thank you very much for inviting me, because I think what I'm going to describe is really quite a change to how the NHS will work, and although that's not a specific area of scrutiny for you, it will hopefully give you some of that background information in terms of any of the areas coming through that you want to scrutinise. So I hope that it's a sort of helpful background for you. So the NHS has traditionally been a treatment service, so people get referred into the NHS. The NHS has traditionally operated as separate units, so you've got hospitals, foundation trusts that were relatively, autonomous. That was how they were set up. GP practices working individually as well. So the NHS had lots of parts within the NHS that work together but separately as well. And what these changes are about is bringing the NHS to work much more as one sort of family of organisations rather than separate parts, and also to work very much more closely with local government, particularly social care, because often people's needs overlap. And that's been a direction of travel. And in Nottinghamshire, we are quite way ahead because we were one of the early integrated care systems. So we've got a really good platform for this work, but it really will very much change how the NHS works. And the other thing you'll see on the 4 aims that we have are to improve outcomes in population health and healthcare. So that's a more, if you like, holistic view about people's health and the determinants of health. And as you'll be aware, part of people's health outcomes are due to the healthcare that they receive, but a lot of people's health is to do with other circumstances, how people's lifestyles, etc. So this is really a way of the NHS embracing some of those wider determinants of health, if you like, and working, really closely. I know in the council you have public health experts and things. We've always obviously worked alongside that, but it's bringing it together much more than previously was the case. And linked to that is tackling inequalities in health. We know that in the county, depending on where you live, that impacts on your expected length of time that you will remain healthy and the amount of time that you will live. And so this is about really targeting specific interventions where those health needs are the greatest, and a much more emphasis on that than has traditionally been the case. The NHS has traditionally been a universal service, so this is it's a way of dealing with those inequalities differently, working alongside councils as well. Productivity and value for money is another area. Obviously, we need to get the best possible impact from the resources that the NHS has locally. And then the final aim is really quite new and linked to this change, is that the NHS explicitly will be involved in supporting broader social and economic development. So that means the way we work with other public sector partners will be closer in partnership rather than kind of again alongside. So that is a new, if you like, aim and duty for the NHS, and very much welcome as well, because we do all need to work very closely as public sector organisations. Thank you. Next slide. So the Integrated Care Board is newly established, and it covers the whole of the county for the first time. So previously, when we had clinical commissioning groups, there was the Nottingham and Nottinghamshire clinical commissioning group, and then a separate clinical commissioning group for Bassett Law. And I'm really pleased to say that part of this change has been that the boundary has moved. So in terms of the county council boundaries, it's now much more coherent with the NHS. So that's good news. And we see ourselves at the bottom of the pyramid. We have inherited the CCG responsibilities for assessing health needs, planning health services, securing the health services, and supporting the improvement of services as well. So those continue, but we've got new duties around integration of care with local government, and also the inequalities side of things and the economic development side of things as well. So they're new elements. And then the other part of these changes is that NHS providers of care, so the hospitals, mental health, GPs, will come together and work much more collaboratively. So the NHS has been, if you like, it's had competition between providers. Now it's working much more to collaboration, and the providers themselves now have a responsibility to collaborate, which is new in the new Act of Parliament. So that's in the blue badge, and we will we will be working to support providers to work together more closely, both at sort of whole county scale across the hospitals, but also in what we call our place-based partnerships, so more closely to communities as well, particularly in the out-of-hospital services. And then obviously citizens at the top of that, and working much more closely in terms of co-producing the services. Thank you. Next slide. We've worked together with across the partnerships to think, how do we really want to work? So it's putting the citizens at the heart, being really ambitious about the health of our local population, and system by default. That means that we think about the population over and above the organisation. So whether it's Queen's Medical Centre or Sherwood Forest Hospitals, it's about everybody working together for that overall benefit of the population, rather than more separately in their organisations. Thank you. Next slide. So we have a number of goals. You can see here we serve 1.2 million population, 70,000 staff across the patch, which is why I think part of that, we are a big employer in the NHS, and that can very much help if we can get more local people coming into the to the health service. Bringing our GP practices to work more closely together. We've started to do that in the primary care networks that we have, and we'll be continuing on that journey, and also helping general practices to work more with other community providers. And again, we are already starting to do that. So the community teams from Nottinghamshire Healthcare Trust are working much more closely now with general practitioners. And next year we anticipate that from the regional NHS England regions, we will get the responsibility to commission opticians, dentists and pharmacists as well. So that will bring together all of those primary care groups with general practice. So I think that's probably broadly what I wanted to say on that one. Next slide, please. So, as I say, we're resetting the relationships within the NHS and between the NHS and other public sector partners as well. And it's really important that we don't just think of this in sort of hierarchical terms, but we bring the strengths of the different parts of the NHS together to work collaboratively. And so that's very much at the heart of it. So we're a family. Some people will be working very closely with communities. Some people will be working in hospitals. Some people will be doing mental health, physical health. Some people will be providing services. Some people will be planning and commissioning services. But we need to bring together the expertise across the different partners to jointly plan, rather than that sort of quite separate commissioner-provider way of working that, again, was a sort of traditional way in the NHS. We're quite a way on, I think, in Nottinghamshire in that regard, but still more to do. Thank you. Next slide. So it's a bit small, but it's what we call our family portrait. So you can see all of the organisations involved in that. And so there's a number of NHS organisations, local government organisations primarily. Next slide, please. So I'll come on to each part of this. So in the new legislation, there are some statutory parts, and then there are some more locally determined parts. So the two statutory parts are the Integrated Care Board, which, as I say, has inherited the clinical commissioning group responsibilities and is an NHS body with integration as well. But then the other statutory component is something called an Integrated Care Partnership, which is a joint committee that's been established between the NHS Integrated Care Board, the County Council and the City Council. And all integrated care systems have an integrated care partnership. And we refer to that as the guiding mind, because that will be a way of bringing together expertise from citizens, public health, the NHS, social care together to say, we think these are the big priority areas to tackle the health inequalities and needs of our population. And we'll draw very heavily from the expertise of the health and wellbeing boards as well, and the health and wellbeing strategies. So it won't be things that you don't recognise or haven't helped to bring. But that's quite exciting, because I think that will join together in sort of statutory terms the planning and the prioritisation across all of us. So we're in recognition of some specific health needs. So, and at the end of this year, that will be our first integrated care strategy that we will jointly develop. The Integrated Care Board I've mentioned, and then we also have what we call place-based partnerships, which are those teams delivering much more joined-up care, and they are coterminous with the way that your localities work. So we've got Bassetlaw, South Notts and Mid Notts, and so the teams are coming together, working really jointly in those areas, along with voluntary sector partners as well, who are very important, particularly in those partnerships. And then we have the primary care networks, which are the groupings of GPs, and they're quite variable in size. Some are as big as the whole of Rushcliffe or Nottingham West, but some are in Nottingham East and Mid Notts, they're a bit smaller. Thank you. Next slide. The other thing to say is that we increasingly will work with other parts of the East Midlands on some of those wider services, the specialised services that are very high complex, low volume services that usually work across a bigger geography because of their nature. So as I say, we've got a good track record and a good foundation, I think, for now that the new Act has come into place. Next slide, please. So primary care networks I've talked about. We have 23 in our area, and as I say, groups of local providers to really make sure that we get more coordination. People say they have to sort of navigate quite a complex set of services, and the idea of this is to make that easier for people in their areas. Next slide, please. And then the place-based partnerships, as I say, for the county, it's Bassetlaw, Mid Notts, South Notts, and they've got well-established partnerships and relationships. Thank you. Next slide. And then provider collaboratives, what we call at scale. They are the NHS trusts, and that includes Nottingham University Hospitals, Sherwood Forest Hospitals, Nottinghamshire Healthcare Trust, also Bassetlaw and Doncaster Hospitals, and the ambulance service as well. So they're all increasingly will work together. Already we're seeing, since COVID, we're seeing them working more closely together. So for example, with the waiting lists for treatment, they do mutual aid, so that depending on where you live, it shouldn't, disadvantage you if the waiting times are a bit shorter at one hospital than the other. So that's already happening and will increasingly happen. So that's the provider collaboratives at scale. That's more your at scale hospital services. Thank you. Next slide. I've talked about the Integrated Care Board that's taken on the clinical commissioning group functions. I think I've covered that. Next slide, please. And the Integrated Care Partnership covered as well. Thank you. Next slide. So what does it mean? It means we will bring together the expertise, clinical expertise, operational expertise, research, understanding the population and strategic planning expertise to bring that together more rather than it operating in separate parts. And also that will help us, I think, working in that integrated care partnership with public health colleagues to think more about prevention and tackling inequalities rather than just the treatment side of it. So we'll see a change of emphasis there. So it's really just more that whole team, or all hands on deck really in terms of working together. Thank you. Next slide. That's it. Thank you. Yeah. Thank you. So hopefully that just gives you some of the background to how the way we work is changing. So thank you.
Thank you, Amanda. Would Prema like to say anything, or are you going to speak later or answer questions from members?
I'll be answering any relevant questions that come up.
Right, that's fine. So thank you, Amanda, for that. Sitting here and listening to it, I have to say our own councillor John Doddy has spoken about this, not least in council meetings. But I have to say, listening to it, it's highly complicated, I think, unless I'm the only one who thinks that. Can I ask, I know it's a government, a government have organised it, but big isn't always beautiful. And how can we be sure that this is going to produce a better health service? And what kind of audits will you do throughout the year? So if we asked you to come back, let's say, a year from now, would we be able to have some details as to how you are now and how this new system has altered the health service, either for better or for worse? Because somebody somewhere needs to be watching what is happening, I feel.
Yes, thank you. Really good points. Yes, and it is quite complicated, even for people working in it. So I've tried to make it as sort of clear as possible, but it is quite. There's lots of components to it. You're absolutely right. I mean, throughout my time in the NHS, actually, there's been different moves towards larger, then smaller, then larger again. And what we are aiming to do this time is really to try and get the benefits of big and small. So we have got some things that we will just do once across the whole geography, where that's either because it needs very specialist skills and we've only got a small number of people able to do that, or more importantly, it's because the services would be offered to that whole population. But then do the right task for the right population scale. So where things need to be locally sensitive and are dependent on local relationships in neighbourhoods or districts or areas, then we would do things at that point. So very roughly speaking, the primary care networks will be the very local areas. And then the place-based partnerships will be where there's a lot of very district-based relationships and where they will have the networks in that local area. So the place-based partnerships will be at the sort of 300,000-400,000 population scale. And then the whole system will work just across the thing. So we will, over time, I think we'll moderate how we work, but at the moment we're thinking for the more services that need to be more sensitive to the local population and the community-facing services, they will be really planned and delivered in those places, whereas some things that are just a set of clinical standards that need to be standardised, for example, or where there's critical mass benefits, then in terms of for the population, then we would do them once. So we're going to try and construct it so we do some things very locally and some things less locally to try and make it the best of both, really. In terms of how we evaluate, we will be evaluating, and some of the changes that we make where we bring services together and integrate services more, we will evaluate the impact of those. So yes, in a year's time, we would be able to talk to you about the things we currently monitor and whether they've got better or worse, but also we will monitor the changes that we make as well in terms of different ways of working. Some of that won't be exactly scientific, some of it will be what we call, qualitative, where we get people's feedback and views about it, so it'll be a mixture of those, but we could certainly do that.
Thank you. Councillor Carr.
Thank you, Chair, fellow councillors, guests. The social, what is it called? The Health and Social Care Act. If ever there was a a piece of legislation written by civil servants in Westminster. I think this is it. I do actually feel for you a bit in that you may come under a bit of criticism, but it's not your fault. It's an act of Parliament that's gone through Parliament. Ideally, it would be nice to have the Secretary of State for Health sitting there, but I'm not sure who that is, or even if it's the same person who it was last week. But we are where we are. If ever there was a time that the NHS didn't need another restructuring, now is it. I have first-hand experience recently of the health service, the delivery of health outcomes, and it's not good. It is not good. And it's not the fault of the staff, it's the fact that there aren't enough staff. And to actually come to the nation and say, do you know what, we're going to introduce this piece of legislation, we're going to change everything again, we're going to have all these different boards, which I think are no different to the ones that we had before, I think it's akin to fiddling while Rome burns, to be honest with you. I mean, my wife, 2 weeks ago today, had a knee replacement operation in the ward, bearing in mind that the waiting list for knee replacements is huge. In this ward, there were 32 beds. Only 11 of them had people in, and it soon became apparent why. There weren't enough staff to actually nurse people in 32 beds. That's the situation that we're in the health service. So for the government to come out with something that, quite frankly, could have been written on the back of a fag packet, in my opinion, is an insult to all of those that have to use the health service and all those people that are waiting for important operations. And if anything, would you give that feedback to your political bosses? Thank you.
Thank you.
Do you wish to answer that?
Yeah, thank you. I mean, yes. I mean, and what I guess the thing I would say is that we're working very hard to, if you like, use the opportunities of working more jointly, more differently, and trying to minimise the sort of disruption. The other thing I would agree about, that there are definitely very significant workforce challenges that we have, and we will do what we can to encourage people to come and work in the area. And we can't, obviously it takes a long time for skilled, people to develop those skills and come through the training, but we will do what we can to encourage as many people to come to the area and stay in the area as well. So yeah, we will do what we can to get the benefits and minimise any disruption from that front line point of view. Yeah. Yeah.
There's always been health service challenges, but I can tell you that within about 100 metres from where I live on my estate, there were 7 health service staff, qualified nurses and doctors, that up sticks and went back to the European Union, never to return. And I know that's not your fault, it's their fault, but would you say that the Brexit situation has contributed to the resources being taken out? You don't like it, do you, when we talk about Brexit and its consequences?
Well,
and its consequence is that it's destroyed the NHS, and you're responsible.
Can I just remind you, this is not a political meeting. We are here to do what is best for the residents we represent. Whether we're talking about politics, talk about them outside by all means. This is not a political committee.
We are representing our residents who pointed out that mistakes that are still being made with regards to resourcing in the NHS.
That isn't necessarily through one reason. These 2 guests of ours are here to carry out the progress. It's not that I don't like it. You haven't been to this committee before, although you've been a member of it. Everybody on this committee is perfectly aware that it is non-political. We are not here to discuss politics of any nature. We're here to see how we can help the health authorities make it better for the residents we represent. Nothing to do with Brexit, nothing to do...
How can health services be non-political?
We here are non-political, not out there. You can be as political as you want, but this committee is an...
This committee is an absolute waste of time, then, and I'm not waste of time. I should go home and look after my ill wife. What a waste of time.
Well, I think everybody else thinks it's been a very beneficial committee, and perhaps if you'd been before, you would have known.
Talk about the big things. I'm not prepared to.
We're not talking about politics. Thank you. Sorry about that.
Councillor Gardner's got a track record for doing this. Does it in Roxton Borough Council? And is a Liberal Democrat Act put on as a show that's on YouTube?
Right, well, thank you for that, but we cannot have any politics in this committee. That is not the idea and the remit of this committee. So can we have Councillor McGrath next, please?
Michelle first, Chair.
Oh,
Ladies first.
oh, right, okay. Pardon? Sorry, I didn't hear all that, but anyway, everybody else did the laughing. Right, okay.
I'm not sure how I follow that, but don't worry, it's I'm not going to go stomping out, that's for sure. I have a few questions with regards to this. I do have similar concerns in the sense that I think in Nottinghamshire you're under enormous pressure at the NHS is for various reasons. Some of that is workforce, some of that is the backlog. And I think, you know, as a staffing and as staff, you're under enormous amount of pressure. And I actually do worry about those staff that are already working in the NHS, which I'm sure you do as well. So one of those questions would be about the consideration of staff with regards to this big whole-scale change, because it will impact. And when you're already under pressure and you've already got, you know, a lot of patients for a lot of people that are looking after, I'd be worrying. I'm just asking about the welfare of staff just in general. So that's the first question. The other question that what I wanted to raise was you talked quite a bit about commissioning of services, which has always happened, particularly in public health. My question is, because I get raised this quite a lot whenever I talk about ICS, is are ICS a mean to increase the commissioning via private companies? Will it increase that here in Nottinghamshire, or do we not know that, or is it going to be a mixture? But I'd be really interested, because there is this vision that is painted that an ICS is a way that a means of privatising more health services. And the other reason that I ask that is obviously the latest things that are in the news, where the East Midlands is one of the highest with regards to backlogs of patients waiting for treatment, and is essentially meaning that here in East Midlands also we've got one of the highest rates of people going to the private sector because they can't get the treatment that they so desperately need here in the East Midlands. I don't know what Nottinghamshire's figures are, to be honest. I don't know if they are available. But it's on a backdrop of that, really. If there's already that pressure there and ICS gives an opportunity for more private sector, is that what is going to happen? And if it is, I think we should have a really open and frank conversation about that and how that will impact the people of Nottinghamshire and how that will work. And like I say, I know that there is a level of commissioning that has always gone on. So it's not like I think, oh, it doesn't go on, but I'm worrying about where we're going in order to, you know, there's a problem, there's an issue, we all recognise that. The last but not least, what I was really interested in, and it might not be something that you can necessarily answer here. So I firmly believe in the integration of health and social care. I think it's the way forward. I've done a lot of work on it in the past. I do think it's the way forward. I think it's a huge job. And I was just wondering, when you talked about tackling health inequalities as one of your priorities, that for here for Nottinghamshire has been one of our priorities, I should think, for about 50 years. And correct me if I'm wrong, there's still a difference of about 7.5 years, is it, between the south and the county and the north of the county with regards to life expectancy. Now, if you're telling me that you're going to start, really delving into some of those health inequalities, how are you going to do that, and what's going to work? And will we see a tangible difference anytime soon? Because I think we should all be welcoming that if it's going to make that difference, because I think we've tried a lot over the years in our health and here as a council to tackle those health inequalities, and we've had a degree of success, but that year range seems to have stayed the same, that difference of life expectancy, even though there's lots of fantastic work that's going on across Nottinghamshire. So I'd just be really interested to know what work you envision, how you envisage that kind of tailing out across Nottinghamshire to tackle some of those health inequalities.
Yes, thank you very much. All really important points. So I completely agree with you about the workforce challenges, and obviously people, have worked incredibly hard anyway, and through the pandemic have many of the NHS workers have done very different, they've changed their roles quite significantly to deal with the COVID. So one of the things that we will do, working with the hospitals and the GP practices across the board and with the councils, is to work together to partly to give people sort of more attention to their well-being. So we're already doing some of that, and we will continue to do that. We've committed to do that to help with the retention, but also to give people some different opportunities so people can more easily move between organisations or work in different settings, because sometimes people just need to do something a bit different for a while. So we'll be looking at both of those, both the well-being and the opportunities to work differently as well, and also to bring teams together across different parts of the NHS and social care as well. And again, we are already doing that and finding that's quite energising, and that's where you can get a lot of innovation by putting those frontline teams together. And as I say, it's quite energising and refreshing. So we will continue. That will be a big area of focus for us, actually. So we're just looking at the moment of how we're going to really cement that into how we work. In terms of I have heard about the narratives around the ICSs being a way of sort of increasing privatisation. To be honest, I don't think the two are linked. I think they are. I think they're different things. I can sort of see why people might have made that link. But in the changes, what these changes do is to get providers to work together more rather than in competition with each other. And big NHS organisations. So it really doesn't, I personally don't think it will make really any difference in terms of the privatisation. We do need capacity from our private providers. They help us with waiting lists and have worked really well with the NHS actually in COVID to help maximise the amount of operations we can do. But I don't see how, by getting the trusts to work more closely together, I don't think it will make any difference. And in terms of what we commission, we certainly don't have any plans to increase the private sector. As I say, we do need to think about the overall capacity from a population benefit point of view, but that's as far as it goes. There's certainly no plans to increase that. You're right, there is a backlog for treatment in Nottingham and Nottinghamshire, just as there is everywhere in the country. We are not, we would prefer people didn't have to wait, but we're not, comparatively, we're not in a bad, in the county, this county is in, in terms of the overall East Midlands, it's not. And we were very fortunate previously because we were called something called an accelerator site in terms of accelerating the recovery between COVID waves, and we were able to do a huge amount of work over last summer actually. So I think our overall position is better than it would have been had we not done that previously. So, but always looking for opportunities to do more and bring people's waiting times down. In terms of health inequalities, I think there's going to be a few areas. So one of our early things that we're doing is to think about how we tackle some of the big causes of health inequalities and differences in life expectancy. So big disease areas. Things like heart disease, cancer, your health status when you're born, things like that. So those are big areas of focus for us immediately. And we have, for example, thinking about, so for cancer, one of the biggest things you can do is diagnose it more early. That makes the biggest difference to life expectancy. And that's why, so in the sort of Mansfield, Nashfield area, we've put the sort of targeted lung health checks there preferentially to try and think this is where we think we're going to have the most undetected cancers. So we will target where we think the biggest problems are to some extent. And we've been working with your public health teams actually to think about health, what we call health equity, which is sort of trying to remove barriers that there might be to accessing health services that might be differential depending on where you live or your circumstances. And we will continue to do that rather, as I say, than just think about everything being standard and universal. So we very much will do that, and I think we'll develop our approaches to that, working with the public health teams and taking advice from them. So that's really just but the starting points are the biggest disease areas, but also the 20% most deprived areas as well.
Thank you, Amanda. Councillor McGrath.
Thank you, Chair. Thank you, and for the great work you do as well, all of you. I haven't seen my daughter come home late or whatever, but I won't bring my family into it. But just a question around what you seem to... It's a fantastic idea, and ideas take a long time. I know you said you're going to come back after a year, but first of all, as Councillor Carr did say, and I won't go into politics, I'm too old, right, is we're already low on staff, aren't we? So is it 70,000 throughout the country, right, doctors and all that? And if we are bringing this together, as you know, right, there's got to be a lot of extra training provided to bring everything together. And the biggest problem we seem to have, well, we definitely do in Broxtowe or the south of, is bringing all the groups together and the transport side of it, right, to get them to their appointments, to this, that. Now, Dr. Doddy told me that there is, supposedly, I'm not saying supposedly because I hope there is, right, a pot of funding there that enables these to bring this transport together, so they're all going to, I mean, there's Queensmed and City, right, and then there's Battislaw, isn't they? They're your three main hospitals in Nottinghamshire. So surely, as we look at it, right, there's got to be a big fund for transport to bring it all together, and them to have the right people in them areas, because as you know, a lot of the people who need operations, you have to train taxi drivers to do the right thing. If you put in a taxi driver in a wheelchair, if they ain't trained, Amanda, it could fall back on you. So what provisos have we made to train the people up to the adequate standards for this to work successfully, to be honest? And we know that throughout the years of the NHS, we've all relied on everybody's good nature. I mean, I've known, well, I'll say it, my mum, my aunties and all that worked in it, and they've done overtime for nothing. So I won't bring money into it because it's people's, how much they care for everybody. We need to pull that together and make sure there's something there. So that's one of my main concerns, is around training the right people in the right places, right, to get this to work. And obviously you must know, Amanda, how long it takes a long time to train them. So is there something already there, please, or in your plan, sorry?
Yes, thank you. So, really important points, and we will, we will only be able to deliver the improvements if we've got the workforce, as you say. So, in part of the changes that I was talking about were that for the first time, the workforce planning will come together with the service planning and the population health needs. Previously in the NHS, the workforce planning has been done completely separately with Health Education England, really. So, and the trusts link in, but it has been really separate. So now that is coming together more. So in Nottingham and Nottinghamshire, we will have a lot more of a say over those training decisions, working with Health Education England. And there's various national changes going on with that as well. But and that will also give us more, if you like, leverage over how those training budgets are working as well, which we haven't had previously. And as we're just working through how we're going to organise ourselves, if you like, to do that. We've got groups in place that bring everybody together, but we're just thinking how we can further strengthen it, exactly for the reasons you've said. But we will be doing training and supporting, and sometimes people are highly skilled, but they just need the opportunities to work in a different way with some different leadership, and we'll be doing that side of things as well. But the training also, and I think we're very lucky with our universities in this area as well, because they're really keen to work with us and think what we can do differently, whether it's sort of people who are qualified who need additional training, or to think about attracting people in the first place and what we can do a little bit differently that will give us that flexible workforce as well, that's probably a bit more able to work with health and social care, working more jointly rather than just in individual parts. So those are all really important areas that are a big priority for us, and we're just, I say, very much strengthening that and going to take advantage of those new opportunities that we haven't had previously. Yeah.
Thank you, Chair. First of all, I'm saying I'm sorry that Kingsmill wasn't put out as one of the areas, because the work done there is absolutely exceptional. I've been treated there myself and so forth, and the doctors, nurses and care workers are under extreme pressure all the time there, and so are the surgeries around in Nottinghamshire. They're definitely on demand, but it's very difficult to get staff. I understand that and so forth. My first question is about the bringing together of all the organisations in the ICS. I've just noticed that Hucknall as again continues to be with Rushcliffe. I don't see why that should be so when Ashfield is with the mid-Nottinghamshire area. And of course the police, the fire, the council, the ambulance service are all together in Ashfield with Hucknall, and yet Hucknall in this new ICS situation will again be out of Ashfield, and it's wrong. It should be put all together. I mean, if you're going to work together, you've got to work together. You know, it's very difficult. And my question on that is, will the groups also meet individually? Will they meet individually as well as a big organisation? Because it's always said that big is beautiful. We shall have to see on this situation. And as I say, I'm sure yourself and all of us will be scrutinising that decision over the next 12 months or so, which is right thing to do. Obviously, as I say, I'm pleased you've not acknowledged the 6 health issues. That they are right, they are right, and that early intervention schemes are essential to improve everyone's health. They're absolutely so. I've been doing that for 30 years now, and unfortunately, some of the time it's been adhered to, and some of the time it's been forgotten. I just hope that that's the intervention schemes really come to the fore now, because we shouldn't be having half the people into hospital. We shouldn't be having half the people using surgeries. And if we'd put these early intervention schemes into place before they reach problems, then that'll be fantastic. I got to say that the lives of children and young people need to have young families now educated at an earlier age to bring up their youngsters through tackling discipline, through obesity, and keeping healthy. They need help. Families need help on this situation. It's got to happen. Early intervention schemes would help thousands of patients with preventable diseases or certain conditions. We've already talked about that situation. As for supporting those with long-term conditions and mental health conditions...
Councillor Wilmot, can you get to your question to Amanda, please?
I'm getting to them. So I mean, we all know that in care homes and so forth, people are under extreme stress when they actually moved into care homes or moved into hospital from their own homes. It's essential that you should get more help into leaving people at home, you know, and the problem is that again it can be price and so forth. Now my 3 questions, here they come. Oh, thank you. So how are we to get the resources to people as quickly as possible when you see how many doctors, nurses and care home workers we're short of at present? We have to remember it can take many years to qualify to be a doctor or nurse. And how will we involve the community in decision making in these care systems? The PCT and the CCG, I remember both them. But over the past 30 years, I've been involved in them all. And now the ICS all promised this, but it did not seem to work. I mean, there's a lot of great work being done, as I say, but I would like to ask those questions. Thank you, Chair.
On the communities. So I completely agree. I think those early interventions working closely with communities is going to make a big difference, and we see the things that will happen in those places as really critical. And the place-based partnerships, the way that they work across GPs, community services, children's and adults, voluntary sector, community workers, we see those as really critical for getting really involved with some of the communities, and we are already seeing that starting to come to life, actually. So I do agree, but I think it's harnessing the joint resources rather than just the individual resources separately that will help with that. And the other thing is that we do know between agencies, we sometimes duplicate things, so different agencies will do their own assessments and things, and we see the opportunity to reduce that in this different way of working. So those are the 2 main ways we're looking initially to target those resources, as well as the public health expertise. But I'll let Prema talk about how we want to involve communities. Thank you.
Thanks, Amanda, and thank you for the question, Councillor. So I think what our aspiration is that we are continuously listening to our citizens in Nottingham and Nottinghamshire, and we're sort of implementing or have implemented a number of ways of doing that. So I think the one that I'd start with first is this. So this is a really important and useful way for the system to hear through you what your constituents are saying about their sort of health and care aspirations. We'll continue to we still continue to have a statutory duty to consult around any sort of major service change or service reconfiguration. So that's another means through which we will hear from people. Amanda touched on the role of the voluntary and community sector. And I suppose this sort of speaks to the question that you raised at the beginning, Councillor Saddington, on how we see the change. And Councillor Welsh, you asked a question about health inequalities. So one thing that's different, I think, in this in the ICS is that we've made a commitment to work with our voluntary and community sector partners. And I think this is a really positive step. I think we would agree that the people who experience the greatest health inequalities are not always engaged with health services, but they are actually engaged with their local groups, their local communities. And we see our sort of working with the voluntary and community sector as a means of amplifying those voices to make those changes, to transform health and care services. We're sort of committed to looking at what data is already out there with regards to population health management. So we're talking about sort of more quantitative data here, sort of large data sets. So we'll continue to sort of look at that. And then finally, I'd probably sort of just say that Amanda made reference to our places, and there are place-based partnerships that have these conversations with representation from people who are working with local community at sort of neighbourhood level, and bringing those sort of voices to the table in those sort of larger committees. Amanda, I don't know if there's anything that you'd want to sort of add.
Yeah, no, thank you. I think, as Premier says, we have made a commitment. We've structured it ourselves so that we are able to work with networks very locally, but also then to bring all that insights to bear, and that will feed directly into the integrated care partnership as well. So at every level of sort of local versus system, we will have that involvement, and we've built that in, you know, so that will be part of our governance and how we work. So we will, that's a commitment.
Thank you. Members, I've still got a list of people, but we do have Sarah Collis here today from Healthwatch, and I think this might be the point. She's wanting to speak, and I think this might be the point to bring her in. So would you like to say what you'd like to?
Yes, thank you, Chair. For those of you that don't know, Healthwatch is the health and social care watchdog, to give it a sort of snappy title, for Nottingham and Nottinghamshire. And we are actually, within the legislation, we have a statutory duty to be part of the integrated care system. So we are one of the partners in this, but we are an independent organisation. In that sense, we've been very interested in working alongside the integrated care system as it's been developed, working with the ICB, the chair. I actually was part of interviewing Cathy McLean, who's the chair of the ICB, and also Amanda in her role. So we're very much integrated into making sure that this new system's approach and way of working is something that is really meaningful to the people who use it, and that the experiences of people that use the services of health and social care are something that we work and talk to people and that we feed into the system. So within that, there is a statutory duty for Healthwatch to be engaged. So for you as members, it's important that you know that and you talk to us, as your insights from your constituencies are really helpful to us. One of the things I was interested in, and it sort of alludes to a number of different questions that have come up this morning, it's the way that obviously as a new commissioning body, the Integrated Care Board, you've talked about provider collaboratives, and Premier, you've talked about how there's a commitment to working with the voluntary and community sector, which we know is very close to people. And obviously the new voluntary sector and VCSE, voluntary community and social enterprise, it's always a mouthful when you start putting us all together in the voluntary sector. Alliance is a new way of trying to, I think, build on the work that was done during the pandemic, bring in the voluntary organisations and agencies that really stepped up to the plate at that time, but are now recognising their role within the system. Often we were outside of the system. So I'm speaking as someone who works for a voluntary organisation. Healthwatch can't survive without volunteers. Always mention that to your constituencies, because we're always looking for new volunteers, in order that we can have that reach. So I do have a lot of insight into the voluntary sector, but I am really interested in how these new provider collaboratives are going to really engage with people, to understand that they're co-designed. On massive scales, you've got the ones which are the trusts, but I know there's other things that will start to be commissioned through provider collaboratives. So I'm interested in your plans and thoughts on how to engage with communities to ensure that we have the patient voice, the service user voice at the heart of creating new ways of working or in this integrated way, and ensuring that the voice of people are at the heart of what you're doing. Thank you.
Thank you, Amanda.
Yes, thank you. So, and again, really important area. So, I completely agree. I think in the pandemic, the way that the voluntary and community services have come forward and have become part of how we work has been tremendous. Actually, it's been really tremendous. And so we want to bake that in now to sort of becoming a normal way of working. And the place-based partnerships will be very much, and we will ensure that the way they are set up does build that in and maintains that. The other thing that we will keep an eye on, and at the moment we will be working very collaboratively with the provider collaboratives. We will, as we move, if and when we move towards them taking on more of those sort of commissioning roles, what we will do is build into that an expectation of them working in that way with the voluntary and community sector, because I think one of the things that we bring to the system is a population perspective rather than an organisational perspective. And sometimes when you're busy, you know, in the emergency department, or you're busy doing operations or busy GP, you see things from what you're seeing every day, and we're sort of our position, we're seeing that in the round. So it's for us, I think, to make sure that that gets built into how people work. And I spend a lot of my time bringing people together and trying to get people to see the different perspectives, to try and get services to work more smoothly together. That's the reason, because it's better for the people that we serve. So we will need to make sure that we put some controls in as that develops further, really. But I think we will commit. You know, we are committed to doing that.
Thank you, Amanda. You didn't want to commit, Sarah, did you? Councillor Bailey, please.
Thank you very much. So I think the main point with the ITS is that it's all about outcomes for residents. Now, a key thing for myself is that if we want to have these outcomes, we need to set clear ambitions and targets. Now, I believe Noel had a slide that specifically referred to a few key targets with numbers. So in terms of those numbers, I hope you don't mind me asking these bit technical questions. How were these targets created? How did you almost get to these numbers? And in terms of the targets themselves, what are the timeframes for meeting these targets? Are they moving targets? And also, what's the review process in meeting these targets? So, for example, you know, if you're not hitting a target the time frame you want it to, what's the process to look back? You know, are we actually managed to do this? And that almost relates to the example you gave with Mansfield and Ashfield, where you mentioned these diagnosis. So, do you go back and look at that and go, actually, you know, we're not picking up so much anymore? How do you assess that? How do you assess that you're not hitting those targets? Because ultimately, I feel that, you know, if we're going to match these ambitions about, you know, reducing inequalities, we need to be able to hit these targets and actually make sure that, you know, value for money, but also better health outcomes. Thank you.
Yes, thank you. No, again, really, really important. So there are some. The way that we're going to be operating is there will be some things which, because we're part of a national health service, that are set nationally that we are expected to prioritise and achieve. And then there will be local things which are probably more to do with our population and the specifics of our population. So some have been set, in terms of how they get set nationally, and it is often to deal with particular problem areas. So cancer diagnosis is one area. We have people that are specifically working on that, working with the places and the providers to put different plans in place to increase capacity in some areas and things like that. And we monitor those outcomes. So the Integrated Care Board will monitor those outcomes, and we have, various operational oversight along the way up to the board. So that's how we will do that. In terms of the local priorities, I mentioned that we've now got the statutory joint committee between the Integrated Care Board and yourselves, and that will have the role of setting what's called an integrated care strategy, and we have to do that by the end of the year. So that will use that mechanism to set our joint local priorities, and we have to do that by the end of this year. So, but as I say, we will draw heavily on the Health and Wellbeing Board and the Health and Wellbeing strategies. So we're not, undermining or anything like that. So yeah. So there'll be some national, some local.
Thank you. Thank you, Amanda. Yeah.
Yeah, so in terms of the strategy itself, how, I presume it'll be in like a 5-year plan and whatnot, or something like that. How often will you be going back and analysing the process? And in terms of the internals, will it be a working plan, working process? And just working out the frequency of how much you're looking at this.
Yes, thank you. So by the end of the year, we will have produced that, as I say, and then by the end of March, the NHS part of the system will have to then have regard to that and turn that into an NHS, what's called a forward joint plan. So it will be one plan for the local NHS that the hospitals will deliver part of, the GPs will, but it's one plan that all the bits fit together, which is again different. In traditional ways, they were all separate plans. So, and then we will monitor them. Some things we'll monitor on a monthly basis, and some of them will have to have, if you like, proxy measures in, because it can take a while for the actual outcome to be known. But are we doing the things that we think are going to make a difference? So we will track those regularly through our routes, and then the Integrated Care Partnership will keep more of a strategic overview on them. But we on a monthly basis we will be monitoring. Not everything obviously would change on a monthly basis, but to make sure that we're along the right lines with the commitments that we make.
Thank you, Amanda. Councillor Adams.
Thank you very much.
I'm sure it feels forever that you're sitting there waiting.
No, it's all right. It's all right. Don't worry at all. Now my laptop's gone off, so I can't see what I was going to ask you. Just 1 second, sorry. The technology is letting me down.
You've waited so long, the top's gone off.
I know, brilliant. Can you imagine? Sorry, it won't be a sec. It's my name I'm more got the problem with. Right, we're there. Sorry. Here we go. Yeah, so just on, I should have really been able to do this without my notes, but on personal experience, I had a fantastic recent visits with the NHS, so they were brilliant. So yeah, although I left with dilated pupils and couldn't see because it was quite bright, that was obviously done on purpose, so that was a positive thing. But just on the appointment side of things, I think where I see the glaring issue is arguably not with the clinical staff, or even those in wherever it be located on the receptions or whatever that be. It's actually in this call processing, and it's, for example, the eye appointment. I missed 2 of them on attempts to try and ring up and cancel them because I had prior engagements. I couldn't get through at all, and I held for 25-30 minutes on the basis that I was desperate to make sure I cancelled it, because again, appreciating the level of appointments that we have, and that we need to ensure that more people are seen. That also strikes with doctors GP surgeries. And I've made this call before, and I've made it directly with Dr. John Doddy as well, around that we need to be sharing resource in that area. And the integrated care system fundamentally has got to address that issue. So if a doctor's surgery loses a member of staff through illness, then it can then be picked up by another doctor's surgery across the way. Because again, I think ultimately, and I know there's a lot of issues with missed appointments, but I think ultimately people do want to be able to manage their care, and they do want to ring up and say I can't attend, because they do value the service that's provided, and also appreciate that other people need to see it. So that's the question around that. Is that going to be a target? If so, what is the plan? Are we talking about a big call centre somewhere, or are we talking about tying in with 101, or how will that operate? And subsequently as well, to aid that, can the app functions be developed more to enable better appointment management, so that again you can take some of that strain off those telephone calls as well, and again form part and cross more departments? I honestly feel that if we can manage that better, I think you'll have less people waiting around for people to turn up that aren't going to turn up. Yeah, that's it. Thank you very much.
Yeah, thank you. No, I agree with your observations, actually. I think this is a big area. So it will be an area of focus for us, and I agree it does need a different approach. What we've done so far is that we've brought together the different parts of the NHS, IT, the sort of IT function. So we've got those working now more as one team, where previously different organisations would just make their own decisions on these things, and then often the systems don't talk to each other and other things, and that's true between the NHS and council services as well. So we're working with the county council on that as well. There will be some things I think that happen nationally, and the NHS app is being developed, and completely agree. And again, we've gone a bit further locally with some of the linking in with the GP records, which I think again we can build on. But there's definitely a lot more to do there. On the tech side of things as well, I do think there's more. Some of it I think will happen nationally, so they're like the NHS app will happen nationally. But there is more, I think, with the GP surgeries as well, and I do agree with you. I think they've all got, not all, but there's different phone systems, different practices have made their own decisions, and actually over the last winter, we had GP practices working more collectively around some of the urgent care demand, particularly if small practices, if you've got 2 people off with COVID, that can it can make quite a difference. So we have started to do that and introduce that, start thinking differently across practices to do that. But that's definitely an area that we will have more of a focus on. So we don't have firm plans at the moment, but we are working very differently to bring the IT together, looking at some fixes that will help that. But I agree with you, the front end is... it does need simplifying and making it easier. And also online, I mean, I'm the same. In work hours, I'm working. So, then I forget to, I don't ring and I forget because I'm busy working. And so I completely agree. If you could do things more online, that doesn't suit everybody, but it will help some people. Because again, I agree with you also, people do generally respond really well to having a bit more control over their appointments and diaries and things, because you know what other commitments you've got. So that it's a really important point, and it'll be an area that we are going to work on.
Thank you, Amanda. I'm mindful of the time, so we've got 3 more speakers, and then we'll bring it to a conclusion. So, Councillor Purdue-Horan, please.
Thank you, Madam Chairman. Yesterday, the former Secretary of State for Health and Chairman of the Health and Social Care Select Committee, I think it's called, Jeremy Hunt, laid out some frightening figures, obviously nationally, and my own research bears some of these figures out. I stayed up late last night Madam Chair, to prepare for this. So forgive me if my question perhaps strays on to some of the answers you've given already. But it does seem we have serious staff shortages to sort of crisis levels. And research suggests the NHS in England is short of 12,000 hospital doctors, more than 50,000 nurses and midwives. And evidence on workforce projections say that an extra 475,000 jobs will be needed in health and an extra 490,000 in social care by the early part of the next decade. And hospital waiting lists reached a record high of nearly 6.5 million in April. As I understand it, the number of full-time equivalent GPs has fell by more than 700 over the last 3 years to March 22, despite a pledge by the government in December 19 to deliver 6,000 more GPs. And of course, the immediately previous Secretary of State for Health, Sajid Javid, admitted the government is not on track to deliver them. Some people would obviously be worried about that, and others would say that we have a national scandal. I don't expect you to comment on that. But bringing it down locally, so that perhaps, I don't understand those large figures, I can't comprehend them, but are you able to outline the workforce challenges faced in Nottinghamshire? And are you able to confirm that sorting out that staff shortage will be a priority for the ICB in Nottinghamshire?
Thank you. Yeah, very important. Yes, I can confirm that this will be a priority area for the ICB. And as I say, the changes in the Act and the responsibilities for the ICB bring together the workforce and the service planning for the first time. So that it has come into our domain. So the challenges that were set out at a national level, I think every area would recognise those broadly. They'll play out slightly differently in different areas, but they are recognisable. Our local trusts, in common with other areas, are doing a number of things, and we will have a role in bringing this together and doing more system sort of working as well. But there's ongoing work around things like international recruitment for doctors and sort of qualified clinical professionals. Also in general practice, we've recruited a number of what are called additional roles, which what was happening was a lot of GP time was being taken up by doing things that other health professionals were more than competent to do. And so we have invested in additional roles in general practice, and that's been helpful in easing the pressures. It doesn't solve it, but it's helpful, and we'll continue to do that. We also have a local kind of staff bank that we set up during the pandemic, actually, which is hosted at Sherwood Forest Hospitals, and we're planning to increase that as well. So, and then people they wouldn't only work at Sherwood Forest Hospitals, they would work anywhere in the area. And some people like that because it gives them flexibility if people don't want to be tied to particular hours. So if that retains skilled people in, on a more of a part-time basis, it all contributes. And then the other thing that we will be doing is working very hard on the retention of staff as well that we have, because people are, retiring early for various different reasons and things. So we're going to be working really hard on that. So that's a big priority area for us. At the moment, we are literally coming towards the end of, if you like, a review of how we can best work to maximise our impact, because this is a new area for us. So we will be very soon sort of strengthening our capacity and our capability to be able to do that locally.
Thank you, Amanda. Sorry. Councillor Tracy Taylor, please.
Thank you, Chair. In your presentations, you referenced the new geography, the new footprint, so we're now coterminous, and you did make specific reference to Bassett Law as an example. And in our briefing notes, we've got briefings about place-based partnerships and delivery structures within the ICS. Just for context, I should say that not only am I a Bassett Law representative, my division is about as far north as it's possible to get without falling into the Trent. So from my personal experience, past use of healthcare services has not only been within the county, so it's not only just been in Bassett Law, that would have been in South Yorkshire for Doncaster, but if I had to go and drag the boys out of school after an accident on the rugby field or something, I would often end up in minor injuries in Gainsborough. If I went to Gainsborough, I ended up with a further appointment in Lincoln. So what I'm curious about in the whole with this now is, I think you spoke as well in your presentation about cooperation or partnerships beyond the borders, but in the round what I'm really trying to ask about is the implications for what I call border communities. And I've spoken of my own geography, my own experience, but I'm sure that I have colleagues around the county on the Leicestershire borders, or maybe colleagues in Newark and Sherwood who have similar experiences of accessing services out with the county. So I'm curious to know how we're commissioning or integrating with service providers for those border communities.
Yes, thank you. So specifically for Bassett Law, we have committed that we won't make any unilateral decisions which in any way cause any disruption for people who would normally go north for their, whether it's planned care or cancer services or accident emergency. So we have committed to that, and we're just doing a formal sort of agreement around that with the South Yorkshire ICB as well. So from a commissioning and a funding flows point of view, we will honour those, you know, those well-established pathways. In terms of Lincolnshire, again, we've got very good collaborative relationships with Lincolnshire, and so any, again, we, you know, those sort of boundary things we would do. I meet regularly with the other East Midlands chief executives, so all of our borders, and if there are border issues, then we can iron those out. So I have regular communications with them. Often it's things like hospital discharges and things like that, where you've got different councils involved and other things. But so we do that. But we have, in terms of the boundary change with Bassett Law, one of the concerns was people often will access their hospital care from South Yorkshire, even though their community services are Nottinghamshire based. So as I say, we've committed to not disrupting those. So yeah, it's an important point. Thank you.
Thank you, Amanda. And finally, Vice Chairman, please.
Thank you. Just a quick one, really. In our document, it says, taking on additional responsibility for planning to meet local health needs and allocating resources. With that, is it going to be more localised per area, so very, very, very localised? Or because it's such a big thing now, is it going to be slightly more with the place-based partnerships? And then with that as well, with regards to databases and recording medical documents, is that database the same across everything? Because I know across community staffing, they have different ways of recording for visits across different counties, and I didn't know if it's the same in Nottinghamshire, where it's one full database that anybody can access people's information, or is it slightly different databases across the board?
Thank you. No, really, really good questions. So in terms of the way that we'll allocate resources, the way that we're developing our how we work is that for things that are more need to be tailored more to local areas, then the places will be very much driving that, because they're closer to those populations. So, but that's usually more of the community and primary services, because they're more community based. And they will all have relationships with the hospital trusts, but they will be closest to their community. So we've already developed a way of working with them that means that their insights are very sort of important in how that works. And then some things where there is no good reason to vary it according to the population, where it's about a set of clinical standards and everybody, you know, you wouldn't want any differences because it's not right from the health, you know, the population point of view, then we would do that once. But it might be that people's access gets a bit tailored for different areas. So what we're trying to do is get the best of the at scale where that's going to be better, but also the local where we need those local insights. And that's where the role of the place-based partnerships will come in for the more local ones more. And then in terms of the databases, it is a really good point, because what we're trying to do is make it so that as many people are using the same systems as possible, and where there are different systems, either to connect them so that information can be shared across them, or to bring everybody onto the same thing. So when I mentioned that we've got our IT experts all working together now, that's one of the areas that they are working on, as well as the sort of front-end appointment side of things as well, and they sort of people having their own records and that kind of thing. So that is a big area for us. But that's developing quite well actually, and we've agreed something called I think it's called an eco platform, which is a way of joining up a lot of data across the different parts of the health and care services.
Well, thank you very much. You seem to have answered everybody's question. I think most people have been able to answer a question. So thank you, Amanda, and thank you, Prema. And I think from this, may I just check with the committee that they would like to leave it to Noel here to invite you back in 12 months' time for us to have an update on how it's all going, the problems you found and the things that you've overcome. So would members agree that in 12 months we have a look at it again, and you come back and report and tell us how well it's going?
Thank you very much. Hopefully I'll be able to show some impact that we're having.
Yes, yes. Thank you very much. Thank you. Members, would you like a 5-minute break? Anybody? Yes, let's have 5 minutes. Yeah. Right, welcome to our change of visitors for the next agenda item, which is the proposed transfer of elective services at Nottingham University Hospital. Can I ask you, welcome to all of you, thank you for coming this afternoon now. Can I suggest that you introduce yourselves and then everybody will know. I think we know you, Lucy and Alex, but never mind, we'll let you introduce. We've got some temporary members, that's why I'm suggesting.
Hi, my name's Lucy Dadge. I'm the Director of Integration for the Integrated Care Board.
Morning, my name's Ian Banerjee. I am the Divisional Director for Surgery at NUH. I also happen to be a colorectal surgeon.
Good morning, I'm Alex Ball, Director of Communications and Engagement for the Integrated Care Board, that I now know you all know exactly what that is, having had 90 minutes on that. So, very pleased to be here today.
I think what we learnt from that, Alex, was how complicated it all is. Right. Who's going to give us this? Excuse me, coughing. Who's going to give us the brief? You,
so it's going to perhaps be the three of us, if that's okay with Chair and members. So we're here today, and you've had a written paper, to request support from the committee to start targeted engagement with our citizens on some proposed moves of specific planned care planned care inpatient services from the QMC site to the city. The specialty services that we're considering are colorectal and hepatobiliary, and Dr. Banerjee will describe those services, how they work now, and how we believe that this proposal will enable them to work better in the future for our citizens. And Alex is going to talk about how we propose to engage with our citizens in support of this proposal. So I'm just going to give a quick introduction and then hand over to Dr. Banerjee. So just to say, on behalf of the Nottinghamshire Health and Care System, we are delighted to have secured £15 million worth of capital to build new facilities on the city campus site, and the construction is ongoing. So what we are constructing at the moment is a ward, 3 operating theatres and an enhanced perioperative care unit. I think we've talked to you before about our clinical services strategy, and that we envisage that the city hospital site will become a hub for the highest quality planned care services, so that QMC can continue to develop to provide excellent emergency care services. We believe that and this has been reinforced by COVID, that if we are able to keep dedicated ring-fenced planned care beds and theatres physically separated from emergency care and start to centralise those on the city campus, it'll help us to both manage waiting lists, manage cross-infection, and also, I think, as importantly for our citizens, create the right ambience for that kind of planned care on a dedicated planned care site. So this is all part of our direction of travel, and as we've discussed before, if we're able to secure funds for tomorrow's NUH, we would want to consult further with the public about how we make this work best for them. So this is our direction of travel. We are, as I've said, we're already investing in additional planned care facilities on the city campus, and in preparation for this winter in particular, and what we expect, and we're already beginning to see, will be a very busy winter for emergency care. We are keen to relocate colorectal and hepatobiliary services into these new facilities at the City Hospital campus, and this will provide ring-fence capacity and some of additional capacity for about 1,000 patients a year to receive their inpatient care on the City Hospital campus. So Dr. Banerjee is going to describe how this will work, what it means for patients, and how staff are being brought alongside us with this. Our paper attaches our impact assessments, which describe the impact of this proposed move on citizens with protected characteristics and also on those who suffer the greatest disadvantage in accessing care. And very happy to take questions on the impact assessments if that's appropriate. But I was just going to finish at this point by saying that as an ICB, we do support this proposal. We do believe it's consistent with our overarching clinical strategy. and as I said, Alex will talk about how we're going to engage with the public. But we do believe that we can move forward pragmatically with targeted engagement, with affected groups, so that we can make the best use of this additional capacity ahead of what we expect to be a very busy winter for emergency care. I'm going to hand over to Dr. Banerjee to describe the proposal.
Thanks, Lucy. I think just in terms of context, the colorectal service looks after bowel cancer, which is one of our four high-volume cancer services in NUH. They obviously look after other urgent conditions such as inflammatory bowel disease and other planned operations as well. The liver, pancreas and gallbladder service also deal with cancer predominantly, but do deal with some non-cancer surgeries. The current situation, and indeed the situation before the pandemic, is that these two services have struggled to deliver the type of planned care that they would like to. And that's mainly because that in being based at Queen's Medical Centre, you are always at the mercy of what the emergency pathway brings you. As such, there are often delays to lists starting on time, and more worryingly, there are occasions where we simply cannot go ahead with a planned operation because we either don't have a ward bed or a crit care bed for the patient to go to afterwards. The other reality is that our elective patients will normally be nursed alongside emergency patients. That was certainly the model that we used before the pandemic, and that's not the greatest environment because it's a busy environment. Acutely admitted patients are often unwell, especially at the middle of the night, and if you happen to be in that bay or on that ward, you're not going to get very much sleep. We talk a lot these days about enhanced recovery after surgery. Gone are the days when you come in and spend 2 weeks in a hospital after an operation. We try and get you up and about, mobilising, eating and drinking as quickly as possible. But in order to do that, the patient has to feel well enough and the staff have to be freed up to be able to drive that pathway forward. And certainly if you can split your elective patients away from your acute patients and create a separate environment, you can actually demonstrate much better outcomes from that planned surgery. So the model here is about creating that separate elective facility round at City Hospital. By chance, we've learned over the course of the pandemic that we can do that safely because, as many of you will know, we had to do much of our cancer surgery up at the independent sector, which was remote from our normal sites. And we created models of care that allowed us to do that and keep our patients safe and well looked after. So the current proposal will be to use the additional capacity that we're hoping to create at a city to accommodate all of colorectal surgery, which is 10 theatre lists a week, 2 a day, to get rid of those inefficiencies of on-day cancellations, to improve the experience of our patients on the day of surgery and post-operatively, and actually make it more productive, because we would hope to see shorter length of stay after surgery, better patient experience, and also avoid the scheduling churn that arises every time you have to tell someone that you can't go ahead on the day that you plan to. HBB, which is liver and pancreas, will also move, but will move in phases and will start with their simpler operations in the first instance. And to bring this into focus, just yesterday we had this exact situation in the list that I was involved with. We had 2 patients. One, we had to put the list together due to other reasons, and my liver colleague was unable to undertake the operation that they planned to because Queen's is struggling with critical care capacity at the moment. So that's why this is important. That's why we think this is the right thing to do for our patients, The creation of an enhanced perioperative care unit also transforms the pressure on critical care beds. It allows patients to be observed in a controlled setting, and then the majority of them will go to the ward rather than needing critical care. That's something that, again, we've learnt about over the course of the pandemic, because we had to create that facility to get more cancer operations done during the first 18 months, 24 months of the constrained situation we were in. So I think that summarises the clinical rationale for why we think this is the right thing to do for our patients. We're not changing any other part of the pathway. So the emergency pathway remains the same. The outpatient and diagnostic pathways remain the same, as do the surveillance and follow-up.
Thank you, Councillor Sanderson. Thanks, Dr. Banerjee. So I think we've heard there, quite a clear clinical and operational and equalities kind of case for making this change. If the committee's content today, then alongside the sort of operational changes that would that we'd want to take forward, we'd want to be checking throughout that time with citizens and with patients to make sure that we haven't missed anything. So we'd do 2-3 things really to kind of make sure that we are definitely in the right place and are kind of doing the right thing for our citizens. We'd want to collate all of our existing patient experience data across both the Trust and the ICB to make sure we've captured any available intelligence already that might influence our kind of implementation of this. And we'd also draw from the intelligence that we've gathered over the last 6 months or so, where we've been talking to citizens about the Tomorrow's NUH proposals. As colleagues have indicated, this is a change which is in line with the overall direction of travel for Tomorrow's NUH. So we've already had a number of conversations with citizens around that idea of looking to bring many of our elective surgery services together in one place. So we'd want to kind of cross-check that information with these proposals as well. And then as we move forward, we'd want to be working with current and future service users. We would run a survey available both either online or on paper. We'd run a number of focus groups and interactions with particular groups. And we'd want to work with our GP surgeries, who would be the sort of referring group into this, with Healthwatch, with other voluntary and community sector bodies, to make sure in particular any potentially excluded groups are really listened to, and again check that we've not sort of missed anything or inadvertently created any inequalities as part of this proposed change. We would sort of collect together and publish all of that information when we had it all together. We'd put that on our website. We'd make sure that this committee had a copy of that as well, so that you can sort of have real transparency around what we found as we move forward with this service. So hopefully that's helpful, and I'll hand back to Lucy just to check if there's anything we want to say in summary.
No, not at all. No, very happy to take questions. So thank you.
Thank you. Got in early this time, Chair. Just a couple of things around the site itself. No surprise that I'm going to talk about parking, because that's my default position on all these things. If we're relocating potentially the capacity for 1,000 patients to the city site, where are we going to put their visitors when they get there? Are we relocating other out of that site, which will effectively replace that capacity, or are we creating new capacity for parking? And also, how does the new site accommodate future growth as well, in obviously as numbers of population increase? How are we looking to ensure that site is not stuck in its current, and we do have the capacity within it to expand it if necessary? Thank you.
Parts of the question, aren't there? So I guess I'm just going to start with the middle one actually, and probably defer to Mr. Banerjee. I feel quite certain that this is a particular specialist area where demographics, mean that it will be a growth area. We are seeing and having to treat more cancers. That is where we are at the moment. Clearly, there is another aspect which is around our prevention, but where we are at the moment, I suspect, unless I'm going to be corrected, that this is a growth area. And you are absolutely correct that it is as a consequence, it's both moving capacity and potentially increasing capacity capacity. And again, I think so yes, there will be more of these particular patients and their relatives coming to this site. But I suppose I take us then back to the whole kind of broader strategy that we've come to talk to you about, is that we need to make sure that our hospitals can provide capacity and access for people who need to be inpatients, who need to come to hospital, and therefore make sure that things that people don't necessarily need to come to hospital for, more generically, we don't bring them to hospital. So it will be a trade-off. But you are right, I mean, we talk about potentially 1,000 patients a year. There will be, no doubt, a period of time while we are rebalancing our services. But what I probably would say is, this is additional capacity for a specialty area that there is growing demand, and it's down to us to make that balance work. I know that doesn't directly answer your question, but it would be wrong not to create additional facilities where we know there is growing demand.
So if I can add to that, so this will firstly increase the productivity of the starting estate, if you like, of 10 theatres. So that will allow some growth in itself. Where these theatres and this ward facility is being built is also where the longer term vision of tomorrow's NUH elective hub resides. So there's the potential to play into that capacity. There's an element of these two services also being set up already to essentially make maximal use of that facility 5 days a week, 50 weeks a year, because of the way that they are staffed and managed. That then means that they could also start to pick up any fallow capacity from other capacity that currently resides at City, and also in future grow into the weekend. So all of those things are about how we manage the workforce. You can't immediately grow into the weekend with elective surgery because you need more beds. Otherwise, you just end up cancelling what you had planned on a Monday. So there is a plan for growth, and it's a really important question because we would expect it to occur.
I think your specific question is, will today, tomorrow, if these facilities open ahead of winter, which is what we would like your support for them to do so, will people be able to park? Yes. But at longer term, we have got to look to realign our services so that if the City Hospital becomes that site for elective services, because we can make sure that car parking is sustained.
Thank you. Yeah, I think that. Thanks for your answers as well. And I think you've nailed it with your responses. I think the thing, it's just the classic, let's not add additional stress to what is a terribly stressful situation for people. And, we, obviously the staff as well. I mean, I didn't even mention the staff, but obviously they've got to park too. So, I mean, as long as that capacity is there, and we're thinking, like you're talking in tomorrow's NUH, well, if we are siting it in a certain location, then, we can maybe build that. I assume, the car parking is in the longer term plan. So you can actually structure that to make some of that effective use early with what you're going to do with this site location. But I actually think it's a great idea to put these services on that site. I think the site's more relaxed. I think getting to it is a more easier and more a nicer experience, I think, than having to get into a city centre. So actually, I can see the benefits from a recovery perspective being based there as well. So yeah, I'm in support, as long as we have parking. Thanks.
I think I was going to ask the same question. I had to smile when Councillor Adams said more relaxed place to go, and I thought, yes, until you get there and you can't find a parking space. But anyway, that's the problem. But Lucy has assured us there'll be parking. Right, okay, Vice Chairman.
Thank you. In the report it says staff have been given the option on whether to move or not. Have any staff decided not to move? And if that's the case, is it going to be easy to fill the vacancies with the shortage that we hear about all the time?
Well, that's the $1 million question. So some staff are staying. This is a journey because, as you can imagine, when you first propose a change to hardworking members of staff, what comes out first is their fears and their worries, which is understandable. Our current state of play is that the the ward, if you like, that these services would have been accommodated on is at a 50-50, so half of the staff are going to move across to City and half are going to stay. Now, we're quite pleased with that because it means that we're going to have experienced staff on both sides and new recruits will come in and bolster those existing staff groups. We're in a similar situation with our theatre staff who will also either need to move or some of them may choose to work across both campuses. It's a highly skilled set of theatre staff and actually there would be roles for them in both the elective and the emergency setting if they decided that's what they wanted to do. And then in the meantime, there's a huge recruitment drive going on at the minute, which we're having reasonable success with, but obviously we've still got some months to go before these services go live. And there's a recruitment event happening this evening, in fact, that we're trying to get people to in the hope that we'll be able to open these facilities fully. At the end of the day, only time will tell if we can fill all of those vacancies. Outside of that, we are looking at other types of workforce and other models to try and give us some resilience on the wards. So instead of just relying purely on doctors and nurses, which would have been the model from 10 years ago, we are recruiting pharmacists who can prescribe, physicians associates who come from a very different training model altogether, and advanced care practitioners. So it's a multifaceted approach, if you like, to giving us this extra capacity.
Thank you. Councillor Welsh.
Hiya. Where to start, really? So I declared an interest at the beginning because I was in hospital over 6 months ago with and I was diagnosed with diverticulitis, if I pronounced that correctly. And due to past illnesses, I was told I was going to have a colonoscopy within 6 to 8 weeks. It's now 6 months later, and I received a letter to say there's no appointment in sight. So my question starts from kind of that basis, to be honest, because you talked about outpatient and diagnostic pathways. I was just wondering how much the impact, it said very clearly in this letter from your Chief Executive of NUH to myself, it wasn't, I didn't have special treatment, it was sent to everyone that was waiting for treatment, where they were saying, you know, the COVID-19 pandemic, etc., had such a huge impact. So my first question around this, and this is again goes back to yourself, who must be extremely busy, and the impact on NUH staff is this outpatient and diagnostic pathway. How much is that still being impacted? And in reality, this move in City Hospital, which I love the City Hospital, by the way, and I feel very defensive of it. I can see it from the bedroom that I grew up in. I was born there, my family was born there, and at the moment it's providing some treatment for my father as well. I don't have anything against what is in this document that's before me. My worry just lies with the fact of the people of Nottinghamshire and where they are with regards to accessing this treatment, but also with yourselves, with regards to yourself and your staff members, which I can only hazard a guess that you're under a lot of pressure and a lot of strain, and backlogs and waiting lists put enormous pressure on your department as it is. So I welcome the fact that you want to do this to improve that situation. But my overall question is, how much do you expect this to actually improve? And is there something else that needs to ultimately be done to get to where you need? And I also don't intend to be critical of anything that's in front of me. I want to make that quite clear. I'm not being critical at all. I think this is fantastic, and I know plenty of people that work in the NHS that are working extremely hard. But I am worried about staff in the NHS, and I think this banding around of, You know, we're short of doctors and we're short of consultants and we're short of nurses. You know, I'm worried that that number is going to get greater because there are such huge pressures. I really am. And that's not getting into politics or anything. That is just a general concern about people that have gone and worked through a pandemic under some of the most extreme circumstances and now coming out of that pandemic and having to pick up all these pieces, and it's a huge job, isn't it? So it's just about that, really. I'm not sure if you can answer that or not, but
Mr Banerjee is much better able clear than me to talk about the service, but I think I would just say I absolutely do agree with you. People have, and this winter is already looking very trying, and you're right, it becomes sort of the more we talk about the NHS, the more we can worry about it. But what I would say about this is a really positive development. This is additional investment in new facilities, which will enable people like our clinical colleagues to deliver the kind of care that we know we all deserve. So, but I hand over to you to talk about what it means in reality.
Yeah, thank you. So first of all, I'm sorry to hear about your experience, and although I understand why that might have happened, it's not what we aspire to. I think it's important to acknowledge that you're absolutely right, and we're worried about our workforce as well. But this is an opportunity, this particular proposal, to improve part of it. A separate part to the one that I think you're describing. There is work going on around the areas that you describe, and the particular pressure that you mention around endoscopy is one that we've been doing a lot of work on. That is very much a workforce issue in the sense of we have, over the last 2 years, because of the impact of the pandemic in particular, and concerns around the fact that those endoscopy procedures might be a way of propagating the virus because it generates aerosols. That has had a local and a national impact on the provision of all endoscopy services. Where we've been able to maintain those services, our staff have had to work in very, very difficult environments, wearing, very onerous kit. And in truth, we've lost significant numbers of staff over the course of the last 2 years, but we are now starting to see a turn. So our efforts in those areas are working. We are also making use of other providers wherever possible to try and catch up, but I think, as you've described, we're still not quite there yet, and we continue to face that challenge. I don't think the two things are directly linked. You're right to ask the question, and sometimes it's the same workforce doing different bits of the work, but we do have a clear-cut plan for that. That means that this particular move won't have a further negative impact on endoscopy services or clinic services. And that's one of the reasons why we've picked these two clinical services, because actually not all of our services would be able to manage a split site service without having a negative impact. Does that answer your question? Thank you.
Thank you. Councillor Bailey.
Thank you very much. So as part of our report, we're also endorsing a targeted approach to patient engagement in respect of the proposals. Now, my question is, in terms of the brief, I'm not sure when you knew that you secured the 15 million. But I also see that you mentioned you was consulting with staff in late 2021. So my question is retrospectively, do you think a public consultation could have been held a lot sooner? And if you were to go back and do it, when would you have almost involved the public? I'm just conscious of the fact that we're endorsing a targeted approach when, retrospectively, if we couldn't have done that, that would have been ideal. So what will you be doing in the future to make sure that we are involving the public?
I think, Alex, sorry, do you want to answer? So I think it's a very good point. We have the money and we are building these facilities. Now, our clinical colleagues' view and our kind of overall as part of the ICB, our system view, looking at how it all works together, for the reasons that Mr Banerjee has described, is the specialties most likely to benefit from moving into these services are colorectal, into these new facilities are colorectal and hepatobiliary. So probably what I'm probably trying to say to you, as is often the case, we have the opportunity to bid for some money. We bid for the money. and then we have to think, this is part of our general strategy. How do we make it work? So probably what I want to say to you is it's not entirely retrospective. It's more we've worked in parallel. It's about, could we get the money? We need this capacity, whatever, because it is great. And I feel very much like Councillor Welsh. I think the City campus is a fabulous campus. I think it's a great place to receive planned care. It's a much nicer, open environment, but it's also got some very old buildings, hasn't it? So when you're given the opportunity to secure money to build new facilities, you're going to do it. And then I think, as is the case with this, we're going to think, as part of the things that we're doing, what would be the best service to look at making that, making the first moves. So it's not so much retrospective, we're kind of doing it in parallel. And I think Alex can sort of describe how we'll make sure that why we feel that a targeted engagement will probably get better patient insights than doing a full-blown public consultation.
Sorry, can I just intervene? I don't think I asked my question properly.
I'm sorry.
Yeah, so I'm aware of that, you bid for the money and then you almost, you look at how can we best utilise the money. I was just thinking, in the report, it seems to be the case that we're going for a targeted approach not because it's better, but because it's an emergency and we're looking towards the winter. So that's one aspect. But I was wondering, how can we retrospectively look at the approach that we've done to actually include the public within the consultation?
So apologies, Anne, I think I knew I hadn't answered your question. I think we would have said that we would suggest targeted engagement is the right thing for a particular specialist group like this, whatever, rather than a full public consultation. I was just trying to describe that we're doing the two in parallel, but I'll ask Alex to pick that up.
No, I think that's right. There's always a judgment call on some of these things. There are obviously enormous benefits of running a full formal public consultation, and we get often richer and more kind of broad information, but that it takes a considerable amount of time. So there is some time, and there are other kind of disbenefits as well. So we don't take that decision lightly, but it would often be the case, as Lucy's indicated, for a relatively kind of targeted proposed change with a very clear clinical case, with a sort of time-limited opportunity in terms of additional financial investment, that the direction of travel would be towards acting as quickly as we can, particularly kind of looking forward to the winter. And therefore that means that whilst we will take very seriously our duties and our plans to listen to citizens and patients, sometimes we have to kind of make that judgment call to get that right. What I would say is, as I think I indicated previously, we have heard already quite a lot from our citizens around the general idea of moving elective care planned operations onto a sort of single site on the city. And as I've described to this committee, I think either last time or the time before, that broadly got an endorsement from our citizens. And then in the relatively near future, when we are out to full public consultation for the wider Tomorrow's NUH proposals, there'll be a further opportunity there for citizens to indicate, have we got that right, have we got that wrong, are there some things for us to think about? So I definitely wouldn't want you to think that we're trying to, and I don't think you are suggesting this, trying to kind of hide this away or kind of push this through. There are just sometimes we have to sort of run things in parallel, as Lucy's described. But that part of the reason why we're here is we want to hear, have we not quite got this right? Have we missed something? And we believe there will be sufficient opportunities to hear from citizens over a sort of ongoing basis as well.
Sorry, and just to finish, to reassure you, we have come to you before actually about doing targeted engagement. I think when you've got a very specific patient population, it's often better to spend your time with that population. We talked to you about neonatal nearly a year ago, I think, and that wasn't a time pressure. This affects one very specific population. We want to spend our time with them rather than gathering a broader set of insights. So I'm inclined to think that we would like to do this for this winter for this patient group. If anything that we find out from our engagement tells us that there are things that we need to change, then of course we will change them. But apologies if the paper gives the impression that we're coming here because it's an emergency. I think we're coming here because we think this is the right thing to do, and I think we would do it this way anyway.
Thank you, Lucy. Councillor Taylor.
Thank you, Chairman. which way to start this. I mean, I'm pleased to hear what the proposal is, not least because, picking up on news reports, commentators throughout the pandemic, in other areas, hearing professionals, medical professionals speak about what our colleagues will often hear me speak about the unintended consequences of our decision. I think in this case, this was an unanticipated consequence of the pandemic, and finding that the separation of services actually showed us that there were different ways to do things. So, I'm supportive of what you're putting in front of us, and glad to hear that we're sort of taking this approach in Nottinghamshire as well. I suppose I've got a couple of questions. First one might be a bit naive if I'm not quite thinking about this properly, but if you're going to split out the services so that you've got emergency and then the elective, and we're talking about capacity issues often, I've got some questioning about if we end up with, you may smile and say it'll never happen, unused capacity at the city site by separating out, and whether with time we might find that the the emergency services follow to mop up what is perceived unused capacity, because so often we'll say, well, we've got a bit of spare here and it needs to deal with. So I suppose I'm asking a question about the thinking, the robustness of the thinking and defending the decision that you're about to take, future-proofing it, not least because I'm thinking about that, about past thinking, the decline of the cottage hospitals, dare I say, and the rush to centralise services frequently. So how if we're taking this as a rationalised, worked through proposal now, how we make sure that we defend that going forward so that we don't get that rush backwards and forwards. And then I spoke during the last presentation because I represent a Bassett Law community, and colleagues from the ICB spoke about how you've got partnership arrangements to still have some service delivery in neighbouring authorities, and contrasting Councillor Welsh's experience, my family experience of service was that consultations were delivered at Bassett Law Hospital, procedures were delivered at Doncaster Hospital, and between a consultation and a procedure it was barely a fortnight. So positive experiences contrary to what Councillor Welsh is experiencing now. But I've got some questions about how this proposal will actually help or otherwise impact those northernmost communities, because for people in Bassett Law, city campus might as well be on the moon in some respects. So, there's a lot of questions there. So my family experience is that those services were delivered geographically close by, but outside what will be our operating footprint now. So some questions about taking this proposal forward and protecting it from future thinking that might be contrary and want to centralise again, and also about the impacts on those far-flung outposts.
If I start with Bassett Law, just to be clear, obviously the residents of Bassett Law are the residents of Nottinghamshire County Council, and they receive their local authority services, their general practice, all their community services from providers that are based in Nottinghamshire. One of the things that and you may have covered it in the previous session, that we've agreed as part of Bassett Law becoming part of our ICB, which I hope we're all beginning to see the benefit of, is that we won't destabilise acute patient flows into Doncaster and Bassett Law. Where they work and where they're operating, the intention is not now to say, because there's capacity there, is not now to say, well, actually, because you live in Nottingham, you've now got those patients. So I think I can give you absolute confidence that there may be opportunities away in the future, but the agreed situation at the moment is that we will maintain acute services flows as they are for the citizens of Bassett Law. And if you're getting a great service from Doncaster Acute Hospital, you'll continue to get a great service from Doncaster Acute Hospital. This particular, as I say, this particular proposal gives us increased capacity for the rest of the county population. I mean, just briefly, just generally around the estate, in the extremely unlikely event, I suspect, that we ended up with empty facilities at the City Hospital, the plan would be to focus our activity in the newer things. So it would give us the opportunity to start to get out of some of the older estate at the City Hospital. But I think we're a long way from there, actually. I think we need additional capacity.
Yes, I mean, I think I was going to make that point. There are facilities at City at the minute that, in an ideal world, we wouldn't be using anymore if we didn't need to keep it going. It's expensive to maintain and keep going because it's old. So in the unlikely event that we didn't need the capacity anymore, then there's an obvious gain for the healthcare economy by using the new facilities instead. I don't think that will happen. And equally, actually, the sort of secondary benefit here is that the capacity that you free up at Queen's Medical Centre will hopefully be able to be used for more emergency capacity, which is exactly what we need, because it will increase flow through the hospital and help with ED and every other pressure that we deal with. If you're unlucky to come into hospital and need an acute operation, then you need to get to theatre as quick as you can, and having more theatres that we can do that in is obviously a benefit if you can find the staff to do that work. I think the wider geography issue is a really good question, and I didn't mention earlier that both of these services are actually regional services, tertiary and quaternary services, so people come from Lincolnshire and beyond for certain parts of the work that we provide. And so again, it is a benefit to all of those patients if they can come prepared for their surgery, and we need a lot of preparation for some of our patients, and then actually get it on the day rather than finding that we can't do what we plan to, and that's devastating for them and demoralising for our staff, as I'm sure you can imagine.
Thank you. Councillor Wilmot, a question, please.
Yeah, I'll be as brief as I can, because I can see the time. Can I say I welcome any system that will help with the improvement of the services at the two hospitals, and congratulations to all the surgeons, the doctors and nurses and the care and ancillary workers, and because at times they are miracle workers, there's no doubt about that. But first thing about the parking situation, I just wondered if you consider publicising that the people can use the park and ride system, and then go on to the excellent bus service that you provide. That would, I'm certain, would help in lots of ways, because I have been to the hospital twice in the last 7 days, actually, at the City, and I couldn't get a parking place. I'm sorry, I couldn't. So that's an issue I'd like you to look at. And as I say, on the park and ride schemes, I've used them just recently, and they've both got capacity. So that's a great opportunity for you. As the report states, this will create additional beds, theatre capacity, and will segregate routine elective capacity away from urgent care demand. And it's clear that urgent action is required. There's no doubt about that. The latest statistics published this month, which I've just looked at, show 68,461 patients overall were waiting for treatment from services across the NUH in May 2022. A total of 64.9% of those patients are seen within 18 weeks, which is, of course, 25% less than the NHS standard that has been set. I have concerns about the lack of a full public consultation. The target dates for these improvements is October, with just public engagement. How long would it take for a public consultation? And how long would it delay your plans? And what is the difference with public engagement and a consultation? Thank you.
So thank you, Councillor Wilmot. I'll let colleagues pick up your particular points around the kind of current waiting list. In terms of the sort of difference between consultation and engagement, this is one of these interesting things, certainly for me, of local authorities and the NHS use the same words in different ways. So I probably need to kind of explain, when we talk about a consultation that has a particular legal meaning for the NHS, it would probably, the actual consultation period itself, last somewhere between 8 and 12 weeks. Prior to that, we would need to go through a number of steps with regional and national NHS colleagues. So you're probably looking at an end-to-end kind of process of 6 to 9 months. So whilst Lucy's been really clear, this isn't about expediency. This is about, we believe it is the right thing to do anyway, to do targeted engagement, because that means we would hear more directly from the relevant patients. There is also a secondary consideration that if we were to be conducting a public consultation, we would not be able to implement these changes before effectively next summer. And that would mean that we would have quite a considerable risk, we believe, throughout the winter period.
I fully do understand your point, Councillor Wilmot, and obviously Councillor Bailey's initial point. I think what I would say is the facilities are being built, we've got the money, we need them, and as we've said, if these services don't go in them, some other services will go in that we'd come back and talk to you about, and ultimately we will start to get rid of our older estate. It's all part of a process, isn't it, of improving, particularly the City Hospital campus for planned care. I think we can assure you, however, that as part of the public engagement, if we have any reason to feel our current, we've given you the impact assessments, we think it potentially has a positive impact on our most disadvantaged and excluded groups given our demography. But if we've got any reason to feel that we can't make this work, taking looking at the improvements it will make to our capacity to manage our waiting lists versus any adverse impacts on our patients, then we wouldn't do it, and we would come back to you and we would talk to you about what those insights were telling us. So it's not a kind of, we just want to get on and do this. We're very happy to be transparent with what our insights tell us, and I'll also explain to you how we will deal with any questions that we get from the public as part of those that insights. But our view is, as a health economy, this isn't just NUH, that the right thing to do is to try and do this so that patients who are on the waiting list now or might come on the waiting list in the very near future get the benefit of this additional capacity this year, and this patient group we feel is the most likely to get that benefit.
Yes, and if I could just add, we've talked about the importance of the workforce, and they have certain skill sets, and therefore we need to, if you like, make a choice around what types of surgery we would want to do in terms of selecting the right type of staff to recruit and attract. If we were to wait for a full public consultation, then that recruitment would need to start after that process. If we were going to be reliant on that. Your point about patients who are waiting, I think, is absolutely right and accurate, and these services have their share of those patients, and this therefore gives us an opportunity to start to make some headway into that by making this use of those facilities.
Well, thank you very much. I think that is all the questions, unless we've got Sarah wanting anything. No. Thank you very much, Lucy, Alex, and Mr. Bangier. I would like to ask the committee what your thoughts are about this move, because it is to us that we are being asked if we will support this change. I am wondering if we support the change, if you would come back in 6 to 9 months and tell us how it's running, whether you've found any problems, how you've addressed them, and in the event anything went wrong before, you would come back earlier. I would have raised exactly what Councillor Adams raised, and that is the car parking. And I do still have concerns, and will mention it, that it will be something we will return to, because we do need to know that these people can park, because they haven't got the luxury of the tram, so presumably it's buses. And if you're feeling a bit rough, it's not necessarily the best thing in winter to be standing at a bus stop. So I have some concerns about the parking, which was raised by Councillor Adams. And how do the committee feel? Let's move that part first. Are you happy to support this proposal? Yes, you are. Right. Anybody against this proposal? No. Just a minute. Noel wants to speak.
Yeah, just so that we're clear, we're agreeing the recommendations essentially at pages 23 and 24 of your papers, so that you're endorsing the proposals to relocate, you're endorsing the targeted approach to patient engagement, you're noting the broadly positive impact on patients with different protected characteristics, and also that to note that staff and trade unions have been consulted on and endorsed the proposals. Are we agreed?
Everybody's happy with that. Should we have a show of hands so that we don't have any problems? Right, everybody is in agreement with that. And can we suggest that you do come back? I'll leave it to negotiate with Noel as to 6 to 9 months, because obviously it depends when you actually make your move. And we will be looking at the car park situation and how you've resolved it. So thank you very much to all three of you. We are just, Lucy, I know this is of particular importance to you. We are moving on to the work programme just before we finish the meeting. And, Councillor McGrath.
You're right. Thank you, Chair. Just on the car park, I'm sure that must come out of a different budget altogether, Chair. So, because if you've got one budget for that, surely the car park must be a different trust. Should we actually have them here, or do you all work together?
Car parking is provided by Nottingham University Hospitals. It's all. They have a budget to provide healthcare and all those support services. But I can't speak for them. But I'm sure between us we would be able to come back to you to talk about how, not just in relation to this, but how our services are developing generally, how we manage access for patients to our sites, between our sites. So it's not a separate budget, but so
that, Lucy, pardon, that would be within the budget for what your movement from A to B.
Yeah. It's how we use the car parks we've got now, how we take in Councillor Wilmot's very helpful suggestion, signpost staff and their patients and visitors to what's available. I'm sure as part of your forward work plan between us, we could probably come back to you to talk to you about car parking more generally, and absolutely how it supports changes like this, where we know that we will have a growth in need for our services.
Thank you. Just to mention to Lucy and Alex, because I know it's particularly of interest to you, at our next meeting in September, we are planning to have EMAS here, and also looking at the winter pressures that you are going to be facing and have started to face. And I was speaking to the chairman of NUH yesterday, and it was my comment that we are here to see how we can help in any way. So we'll be interested to see what points you can come up with on that, because I know you are particularly interested in that, both Lucy and Alex, because you've mentioned it before. So just thought I'd flag that up before you go. Thank you very much to all three of you. So, we can, I'm mindful of the time, so we can just look at the work programme. If anybody has any comments. It was suggested that we bring the East Midlands Ambulance Service in along with the winter pressures, because they are as one. If one can't work, the other one can't work. So we're bringing them both in. And also, we would like initial discussion on the future of Newark Hospital and the different services that you're going. Yes, please. Thank you for coming. And the impact that the offer of new services could have at Newark Hospital, because we as a committee need to be brought up to date on this rather than hearsay. So does anybody have any problems with that on the September work programme? No? And then we are coming back in November to tomorrow's NUH, and we should be having an update of elected services at NUH. Noel says we're moving it. This work programme really has to be a little bit movable by its very nature. But I might say, I think we might know somebody who comes next month who we all know very well, because when we lose our chief executive, it will be he that comes here to report what is happening at Queen's. So I think we've got some interesting meetings ahead. It will be he who comes to give us an update. Noel, you wish to speak?
Yes. Yes, thank you. I was hoping to harness the energy that you had at 25 to 11 to discuss the work programme this time round, but that wasn't to be, but it couldn't be helped. And I just wanted to say that what we've tried to do for the iteration in front of you is to look afresh at the long list of stuff that we hadn't yet scheduled, bearing in mind that we have now additional scrutiny capacity in other places within the authority. And what I wanted to do was to concentrate some minds and get sort of your endorsement really of the approach, not to sign off one each and every item that is within there, but just that if you agree that the approach that we do that's a bit more focused, that we have a maximum of 3 items that we can look at any given time, and we want to just explore different ways of moving stuff forward of interest to you. We're also conscious that there are new members of the committee this year that may have had other gaps that you could identify in what we've produced. But what we would hope to do with your blessing is to go away and tighten up the programme for the rest of the year, and to be able to have perhaps a more substantive discussion on it again in September, if that's okay.
I can say, members, that we will be looking at dentistry. It's a thing right across the board that people are having problems with, pulling their own teeth out and sticking blue tack in. That will not do. So we need to be looking at that, members. The other thing is, it is my wish that the chairman and vice chairman of this committee and the other scrutiny committees that we have meet, so that we can have a look at what they're planning to do in their scrutiny committee, so we are not overlapping. Because as Noel said, we used to be one scrutiny committee, now we're 3 or 4. And they could be looking at the identical things we're looking at. We could always have a working party that joins with a working party to another scrutiny committee and look at the things from 2 angles. So we just need to look at that. It's far too late in the year now, but we'll certainly have it organised early September. Tracy, you wanted to say something?
Thank you, if I may, and bearing in mind I might not get a chance again because I'm a stand-in today. Noel, you don't know me very well yet. I've still got the energy for this item that I had at 25 to 11, and I'm going to get the questions in now. Okay. So as I'm looking at the unscheduled items, top of page 14, Mental Health Services Review Update. That doesn't explicitly reference children and young people, but that is obviously very close to my heart. So I am assuming that when you're looking at this, you will have that explicit focus of both adult and children, and I know that the chairman and I have already spoken. Operation of the multi-agency safeguarding hub. In my notes, I've marked a question, why here, as in why this committee, because I don't particularly see the MASH as a health scrutiny subject, my personal view, and I'm obviously looking at the MASH as serving both children and adults. because there are both sides to the mash. So I suppose my question to the chairman or to the committee would be whether that subject should go, as you've noted, whether it should go to the CYP Select Committee, or indeed whether it should go to both children's and adults, because there are both facets, or whether, because it has both facets, it should actually go to the overarching Overview and Scrutiny Committee. So that's my question, but I'm sort of suggesting it probably doesn't sit foursquare in health, if at all in health. And then, again, notes to myself, Chairman, on long COVID, and the notes in there about impact, particularly on children and socialisation. My perspective is that they are not the same thing. That's not to say that there haven't been significant impacts on children and their socialisation because of COVID, but I would question, in effect, what is potentially the impacts of extreme circumstances, as opposed to medicalising all experiences. So that's just a perspective in terms of the impacts that children are experiencing post-COVID. Again, I see as perhaps something for the Children's Select Committee, which you have in your notes.
I think that is one thing that we were looking at for a working party, because it's slightly changed its title and being moved a bit. It was looking at long COVID and the effects on the population. So we were going to look at it from the socialisation point of view as to all these people who weren't able to go out and about. And if you look at the older people who used to go out for various village lunches or things, what are the community, what are we doing to bring these people back to feel that they have got a life outside their house? This was basically how it came about. I don't know how it got linked to children. It was probably because I mentioned it, and of course I've got a grandson with long COVID. But it wasn't just to look at children, it was to look at the middle-aged people who used to go out and have their lunches and this type of thing. And so many people now feel they don't go out, particularly with the COVID figures rising again. And it was to look at what the community is offering for these people to be able to socialise again. I think that's what we were doing. Is that more acceptable?
You understand, Chairman, why I'm so precious
Yes,
about children and young people.
And this is why we're going to have a meeting, so we're not treading on each other's toes.
It's not so much treading on toes, Chairman, it's just...
We don't need duplication.
No,
this meeting lasts long enough without having duplication. Anybody else wish to say anything? Michelle?
Yeah, just to say a lot of these have been spoken to about with me and Sam and Martin in the briefing about some of these things that are on there and whether they're more appropriate to go to the Children's Select Committee. And I think we were in the point where we were about to communicate with yourselves.
Yeah.
And we forgot. So that's the first point. The second point, which I think is a real pressing issue, and this isn't just anecdotal, this is, you know, a serious consequence of what's going on, is looking at those early diagnostic pathways that are currently being seriously disrupted across Nottinghamshire. Not so much in Kings Mill when I've looked at the data, but certainly in the city, Nottingham City Hospital, our NUH hospitals, there is a problem that is getting worse and worse and worse with those initial screening when someone has those initial symptoms. And it was passed off a little bit, I think, there, but colonoscopy is the other colonoscopy that I can never pronounce, and I apologise for that. There are huge, huge backlogs, even if you have symptoms.
Yes, I think...
I am honestly really, really concerned about the consequences of that on people living here in Nottinghamshire. Even if you've had evidence of cancerous cells previous to that, you are still waiting 6 to 7 months. And that's massive. And I'm not saying this, this is a fact, and I think we need to ask those questions, because it's a problem that I think is only going to get bigger. And I think looking at the early pathways diagnostic, even if we just concentrate on cancer. I don't know, but I think asking those questions and having someone to come in to say what happens if you have the symptoms, what is different in that pathway, I think is really, really important.
I certainly agree with you, and I think it is one thing that this committee can look at as to the effects of elective surgery, diagnosis, etc., etc. It's a long, big item to look at, but I certainly think it's something for this committee, so I agree with you totally. Yes, John.
Thank you very much for letting me just talk. On the scrutiny plan, the situation about the mental health service review, I think that's essential. It should be brought forward from many of the others, and the frail elderly at home and isolation, that needs to be discussed. I'm meeting a lot of people at the moment that are frail and elderly, and the services need to be really looked at, very strongly. And finally, can I welcome the inclusion of the East Midlands Ambulance Service? Absolutely essential. But what I'm saying is we're down to meet them every year. At the moment, with the serious situation, I think that should be every 3 months, to be really honest with you. It's up to you, of course, your chair, but I really feel we should be looking at that more closely at the present time because of the situation. Thank you.
We're certainly looking at it next month, and we'll see how we go when they come next month. So, Francis.
Thank you, Madam Chairman. Very quickly, thank you on behalf of David Martin and Councillor Debbie Darby. Thank you for including the Newark Hospital on the work programme. Also, one of the things we feel that could be added is access to GPs and other staffing issues. We asked for this to be included in a future work programme, and an investigation is done on access to GPs.
Yeah, can I just stop you at that? This committee has looked at that, and we went off to look at other issues, and we need to go back. We need to go back and have some more GPs in here to tell us how they're changing. Now we have virtually come out, well, dare I say it? No, we haven't come out of COVID. Now things have changed, how they're addressing seeing their patients, and how do patients get access, because we're very aware that a lot of people can't get access to GPs. So it is something that we have started to look at. We've had 3 GPs in here to tell us how they were coping during COVID. 3 actual GP surgeries came in here. So we got that far. Then we had to break off because we've had the maternity to look at and other issues, but it is definitely down to look at it and continue with. We haven't made any recommendations yet, so we have to return.
Thank you.
Okay.
I do realise that we're going to have a long queue out there. It's so many people coming to see it.
Anyway, so has anybody else got anything else to mention? Thank you for your patience, everybody. Oh, Councillor McGrath.
Well, I know I was remember I got a walker. If you think about another one, please, Chair, right, add to the future, it's a 111 service. Because I've had a number of complaints, right, I just want to know how they decipher the information they get. Because obviously a lot of people are told not to go to ring 999 on emergency.
And they're using it.
Yeah, and they're using it more. Right, I've got no problem with the service, but I want to know how to define what information.
Noel has taken a note, so we will certainly look at it. We've got lots of things to look at, but as I say, we don't want any crossover with the scrutiny committees. So thank you very much, everybody. We finished virtually today for the summer recess. Enjoy, and we'll all meet again in September.
Thank you, Chairman.
You've had a lovely time. Well, one person.